and welcome to a new series on CME series on lysosomal disorders in a systems approach way or through the organ systems, where we invite a subspecialist to discuss different disorders as of through an organ. But today's talk that we invited Dr. Vala Al-Hertani from Boston Children's Hospital to start with a wholesome approach that she's going to be talking about the multi-team approach to lysosomal disorders. As a brief intro for this topic, I actually gathered some slides, which are actually, that is probably you have seen them before, but I just want to remind you what the lysosomal disorders are and, how we manage them in a multi-system way. So lysosomal storage disorders, while they're rare individually, honestly, that are common disorders in a collective way. So the incidence is almost 1 in 5,000 births. So every half an hour, a baby with a lysosomal disorder is born. However, most lysosomal disorders, especially the ones that are recognized later on, such as the adult or juvenile, later juvenile subtypes, actually miss the diagnosis early on. And as I said, the LSDs can present during early infancy, childhood, and adulthood. And lysosomal storage disorders, even though there may be one system predilection, such as the hematopoietic system in Gaucher disease or cardiovascular and vascular system in Fabry disease, they are truly multi-systemic disorders, such that requires a complete clinical examination that we deem to be head to toe. And neurologic exam and also a gait exam is an essential part of the evaluation of a patient. And it is important to know that there are specific therapies exist for some lysosomal disorders, and the number is increasing as days go by. The reason for that is this requires a change in the course, how we care of the patients and how we design the multi-team approach to these patients. And as we know that there is a disease spectrum in lysosomal storage diseases, there are purely neurological forms such as the Sanfilippo disorder, where there are also peripheral forms such as in late onset Pompe disease. This is a slide from 1990s. The reason I want to give you this as an example, because truly the landscape of lysosomal disorders in the clinic is changing. So as you see, this is the Australian data where the most load of a lysosomal clinic actually comes from the clinical recognizable patients by phenotypes, such as the MPSs, or severe neurological phenotypes, such as Krabbe disease or GM2. However, with the advent of genomic and genetics approaches, now we have less recognized presentations, and especially more adult type patients exist in our portfolio in the lysosomal clinic, and also, which is also important because more therapies are being introduced. So there are pros and cons of a comprehensive or a multidisciplinary approach to a patient with lysosomal disorders. You can ask why there are cons, because it is a pro thing. Is that right? Obviously, such an approach will allow for early detection and management of complication and initiation of specific therapies. And also the introduction of new therapeutic modalities, because it would be easier or allow the team to select the patients for these upcoming clinical trials. And also this will allow the team to offer psychosocial support and better quality of life to the patient, and also which is important, transition and long-term care of these patients, especially from the pediatric to adolescent clinics to a young adulthood and later on. However, what a multi-specialty clinic could also jeopardize or have challenges. Obviously, the resource allocation, coordination among different specialties, and access to expertise, and which is, I think, the most important thing here, because we don't have enough experts in the field to spread the knowledge and education, and this is why we're doing this series actually. And also coordination and communication, and also offering such a care may, even though it had all the good intentions, may lead to inadvertently to fragmented healthcare systems, because the patients will get shuffled to one place to another without a leading team. Okay, so obviously there needs to be a limited awareness and education. By saying that, I would like to invite Dr. Al-Hertani, who holds a combined honors and biology and biochemistry degree from Dalhousie University from Halifax, Canada. She received her Doctor of Medicine degree in 2005, and she got further trained in residency in medical genetics and also in medical biochemical genetics, and she held various academic appointments at Human Genetics, Pediatric and Medical Genetics at McGill and University of Calgary. And to the US's luck, she decided to move from the border to Boston Children's, where she holds an assistant professorship title, and she is the co-director of the Lysosomal Clinic, and she also actually runs a clinic at Brigham Women. Vala, I would like to invite you to present your talk on challenges in the current care models for lysosomal disorders.
Thank you very much, Dr. Goker-Alpan, for this fantastic introduction and also for your very kind invitation. I'm just going to share my screen. And thank you for everyone in attendance today. I think some of you may have heard some of the content that I will discuss today, but I do feel this is a very important topic. And thank you, Dr. Goker-Alpan, for bringing this up as a discussion that should be had in a wider arena. So these are my disclosures. And so today, really, the purpose of this talk is to take a bird's eye view of the care models that we have in place that will apply to lysosomal disorders and inborn errors of metabolism, and how precision medicine fits in. And are the care models that we currently have keeping up with the advancement in precision medicine? There's a lot of advancement happening with therapies, but I'm not sure the care models are actually keeping up. And the infrastructure for these care models is pretty significant, and making changes is a huge task to tackle. So we really need to start thinking about these things now for the future of our patients and the care that we offer our patients. I would also like to cover access to adult care and transition to adult care as a sub area of multidisciplinary care. And then I would like to open it up at the end in the discussion for ideas from the audience on how can we make a shift in these care models. But I always like to do a brief introduction about precision medicine because it's so important for lysosomal disorders and inborn errors of metabolism. So there was a precision medicine initiative put in place January 2015, and it was launched to accelerate the understanding of individual variability and effect on disease onset, progression, prevention, and treatment. There are 3 arms to this initiative: discovering new biomarkers predictive of future disease risk, and also extremely important for clinical development of newer therapies, discovering determinants of individual variation in response to those therapies, and then enabling targeted clinical trials with rich clinical data. And although one may think that precision medicine is a relatively new term in medicine, it's really not. The founding father, as we like to call him, of inborn errors of metabolism, Sir Archibald Garrod, was the first to describe the idea of biochemical individuality in health and disease. And in a manuscript in 1902, where he discussed the incidence of alkaptonuria, another rare disease / inborn error of metabolism, he commented that the thought naturally presents itself These conditions, alkaptonuria, albinism, cystinuria, are all mere extreme examples of variations of chemical behavior. Just like there are two individuals of a species who are not identical in bodily structure, neither are the chemical processes. So really, I see there are many types, and this can be an entire talk by itself on precision medicine, but I really see inborn errors of metabolism as a perfect subset of conditions for precision medicine. And why is that? Inborn errors of metabolism are a subset of clinical genetic conditions. They can be rare or ultra rare. And the underlying defect typically is a deficiency of an enzyme, a deficiency of a cofactor, leading to some sort of toxicity, leading to cell death, or leading to the inability to generate energy, which is needed for bodily function. So, and you know, this is just a diagram to show you all the biochemical reactions and how intricate these reactions are and how intertwined they are. And so you can imagine if we simplified it down to a schematic like this, if an enzyme is not working, the substrate increased, there are downstream effects of this substrate accumulating, including toxicity, and then not being able to generate a product that is needed for the multitude of reactions is also challenging and problematic. Sometimes it's not the enzyme, sometimes it's a cofactor that is missing, but this is really the basic framework behind inborn errors of metabolism. So as you can see, they lend themselves very well to precision medicine, because just looking at that very simple diagram, you can think of different ways to develop therapies. And in fact, this has been the basis for many of the therapies that we have right now. So replacing the missing enzyme, we have multiple types of enzyme replacement therapy, removing or scavenging toxic substrates. We do have examples of that. We're providing the missing product or providing the missing cofactor. So what these treatments have done for, I would say, you know, I'm lumping here lysosomal disorders and inborn errors of metabolism since multiple decades now, is they've improved survival significantly and they've improved outcomes, but we know they're not curative. We also know that many of these therapies, whether they're dietary, oral, and repeated enzyme infusions, require lifelong compliance. And this is something that is quite difficult to achieve for our patients. So there is, as many of you know in the audience, there are multiple new types of therapies that are coming down the pipeline that will even, again, change the natural history of these disorders. So as I said, inborn errors of metabolism are a subset of clinical genetic. Lysosomal disorders are a subset of inborn errors of metabolism. There's about 70 monogenic conditions. They're individually rare, but with the incidence that Dr. Goker-Alpan mentioned, they're not that rare. And there are many different ways you can develop a lysosomal disorder. It could be a lysosomal enzyme deficiency. It could be an impairment in membrane-associated protein, defect in enzyme activators, or modifiers that alter the lysosomal function. We typically categorize the lysosomal disorders in categories such as mucolipidosis, mucopolysaccharidosis, sphingolipidoses, as this schematic shows here. So as Dr. Goker-Alpan mentioned, lysosomal disorders as a group affect nearly every organ and every system. They are multi-system conditions, and therefore when you are caring for a patient, you have to think in a systematic fashion. Depending on where you are on the phenotypic spectrum, because this is something else that we see quite commonly with lysosomal disorders, is the condition, the phenotype is on a spectrum. You can have symptoms varying from relatively mild somatic symptoms to severe somatic with rapidly progressive neurological manifestations. For example, I'm just going to pick the sphingolipidoses, and Gaucher disease is an example of sphingolipidoses. Everyone knows in the audience that Gaucher disease is a multi-system disorder. Some of the main features include hepatosplenomegaly, anemia, thrombocytopenia, bone disease, bone crises. Onset can happen in the first or second decade, but may present anytime between infancy and adulthood. And we have this classical categorization of Gaucher disease of non-neuronopathic type 1 versus neuronopathic type 2 and type 3. But in reality, it's really a continuum. And in fact, patients with type 1 also manifest certain neurological findings, as well as the increased risk for Parkinson's disease and Lewy body dementia in patients with type 1, as well as carriers of Gaucher disease. So just looking at this schematic very quickly, shows you some of the organs that are involved in Gaucher disease, and very quickly you realize if you are a geneticist or a metabolism physician, that your patient needs to see a hematologist. Your patient is going to need to see a orthopedic surgeon. You're going to need to collaborate with your radiologist. You may need to see gastroenterology to look at the liver. It's not mentioned here, but there are liver manifestations outside of hepatomegaly in Gaucher disease. So very quickly, if you look at every condition, you can determine that you're going to need help from multiple specialties. And this is just one final slide that I wanted to talk about before moving on to the challenges. The majority of drug development in inborn areas of metabolism has really been focused on lysosomal disorders. So lysosomal disorders as a field have laid the framework for drug development and therapies that are life-changing, which is really, really fantastic. And the therapies that we have currently: enzyme replacement therapy, small molecule substrate reduction therapy, and of course, hematopoietic stem cell transplant. But there are lots of therapies coming down the pipeline. There are lots of clinical trials that are happening at your site and many other sites, including, for example, second generation ERT that is able to bypass the blood-brain barrier, an obstacle that we face with the first generation, intrathecal, intracerebral ventricular delivery of ERT, combining ERT and small molecule therapies, and of course, I think in 2020, there were at least 35 clinical trials for gene therapy in lysosomal disorders, and I'm sure the number is much, much higher now. So the reason I wanted to talk about this is this shows you that the advancement is happening at a fantastic rate, and if it could be faster, that would be even better for the care of our patients. But I don't think that the care model that is being carried out in clinic or in hospitals or in centers is really keeping up with the advancement of therapies. And this is why I think it's important to have this discussion. So I broke down the challenges into 4 categories, and I'd like to go through one by one. So this is the challenge that we talk about the most. So the diagnostic odyssey, the delayed diagnosis. Why does this happen? Most of the patients and families, their first point of contact is either their primary care provider or a non-lysosomal specialist. So that specialist or primary care provider has to think about lysosomal disorders to refer the patients and their families to the right center and the right specialist. And that it takes time before this happens, and this is part of the diagnostic odyssey, as I'm sure you've heard many stories along those lines. Another obstacle for delayed diagnosis is urban versus rural centers. Most large tertiary care specialty centers are in urban areas. The rural areas don't have as much access, and therefore having a referral to go to an urban center does take time and may not be as timely as if you lived in an urban center. Atypical adult presentation. This is definitely an issue with the later onset presentations for some of the lysosomal disorders. The patients are underdiagnosed. So they also have their diagnostic odyssey. And because typically those presentations can be on the milder end, that diagnostic odyssey can be significant, multi-decade diagnostic odyssey. And then of course, if there was equal access to genetic and biochemical testing across the board at every center, that would be a game changer, but that is not the case. Not only is access to genetic and biochemical testing not equally available at every center, but also there is the obstacle of insurance, and not every insurance would facilitate the patient to access this type of testing, which again further delays diagnosis. Another challenge that I'm seeing more and more frequently, being a physician working in a large center in Boston and seeing patients from many areas outside actually the greater Boston area, including Maine, New Hampshire, Rhode Island. And this is actually even accentuated even further by newborn screening, where we're now able to, which is great, identify patients as infants with lysosomal disorders, like, for example, Pompe disease, and identifying a patient with infantile onset Pompe disease. But I have patients who live 6 to 8 hours away, and once the diagnosis is made, they have to go to an infusion center for their ERT, and they have to drive every week or every 2 weeks, depending on the ERT and the diagnosis, 6 to 8 hours to come to the infusion center. There's a financial cost to that. There's a time cost. There's significant burden on the family, especially if there are multiple other children. So this is, and unfortunately, this does lead to compliance issues and will impact outcome. So although this is not discussed as much because it varies between state to state and region to region, but this is a major challenge that I'm seeing in multiple patients at my center at the moment. This next challenge I want to spend a little bit more time on, which is there are two types of adult patients. There are the adult patients who are identified as pediatric patients, and then they were in pediatric care until they reached 18 years of age, and then they transition, and then they need adult care. And then there are the adult patients who present as adults because they have adult onset conditions. And I will talk about both. What we do know, as I mentioned, the availability of therapy and the types of therapies we have available have changed in natural history of rare diseases like inborn errors and lysosomal disorders. So 90% of patients now survive past 20 years of age, and 50% of those patients are adults. So although 50% of our patient population are adults, we actually are taking care of the adult patients in pediatric centers. So this is problematic because pediatric phenotypes are more understood than adult phenotypes. The complexity of adult care, because then there are other elements and caveats that you have to add when someone is an adult that you don't think about in pediatrics. If you continue to care for adult patients in a pediatric setting, I'm not sure that that is the most optimal way to do it, but this is all historical. So historically, most patients with rare diseases were pediatric patients, so the pediatricians had the most experience, and this field was under the purview of pediatricians, which also led to adult physicians having very limited familiarity, either with the diagnosis or with the management. But as I gave one example, I'll talk about another example in a minute. When you have complex conditions in adults, as well as just regular age-related health problems on top, I'm not sure that the pediatric center is the place to be for the most optimal care for our adult patients, and we need to have expert adult providers. I came across actually these two surveys, one very similar surveys of metabolism physicians. One survey was in the US and another survey was in Europe. And the survey was really trying to elicit more information about how is the care provided in those different regions in the world. And interestingly, 98.9% of US physicians said that they take, metabolic physicians or lysosomal physicians, they take care of both pediatric and adult patients in pediatric settings versus 84% of European physicians. European centers were more likely to have separate adult metabolic clinic, and they were more likely to have specializations. So a lysosomal clinic, small molecule clinic, so on and so forth. In contrast, in the US, adults, as I said, predominantly receive care in pediatric clinic, and they're predominantly not as specialized and tend to have limited access to adult care. Many tertiary US pediatric hospitals are standalone institutions and unaffiliated with any local adult institution. So you can very quickly imagine what kind of obstacles our patients face, especially as they enter adulthood or as adults, as they continue to come to a pediatric setting for their care. If we thought about the other angle, adult hospitals that are not affiliated with pediatric institutions, for the most part, typically don't have genetic, metabolic, or lysosomal specialists, and they may not even have some of the, let's not talk about the complex therapies, but even the more simpler therapies for metabolic disorders and lysosomal disorders. So I don't think there's one system. I think Dr. Goker-Alpan mentioned this a little bit. There is no one perfect system at the moment. Both models can result in care fragmentation. And specifically when we're talking about adults, prevent the adults from receiving, so adults, meaning older pediatric patients who have been under care in a pediatric setting and then getting older and transitioning to an adult setting, they're not really getting the necessary multidisciplinary care that they need. So what about access to multidisciplinary care, both in pediatric and adult setting for patients with lysosomal disorders? And this is the next challenge that I'm seeing quite frequently. So when I say access to multi-D care, I mean, you know, I gave the example of Gaucher. You're going to need orthopedics, you're going to need neurology, you're going to need gastroenterology, you're going to need hematology. Do you have access to all those specialists within one center? Typically in larger academic centers, yes. But as not every center is a large academic center, smaller centers, patients who go to smaller centers may not have that access. So what that means is now they have to travel for their care to other centers. And then there has to be some sort of continuity of care and flow of information from the various centers back to the supervising rare disease physician to make sure that the plan is being followed for the patient most appropriately. And most of them, even in the larger pediatric settings or in the smaller settings, there is really insufficient adult multi-D care. So let's, for example, look at MPS. There was this really nice table summarizing all the different specialists that you need for the care of all the types of MPS. And in fact, the table was pretty extensive, but I noticed that there were no genetic counselors. I feel like you need prenatal genetic counselors, lysosomal genetic counselors, you need obstetrics, gynecology, and that was not in this list. But you can see in the list that it's an extensive number of specialists that are needed for the care of the patients. And so if you are not in a center where you can easily access those specialists, then that means that you have to travel, you have to find the time, you have to find the money, and then there has to be some sort of coordination with the primary center. In addition, you know, most of the lysosomal disorder physicians now have a lot of experience with enzyme replacement therapy, how to deal with infusion-associated reactions. We need that kind of expertise for gene therapy. So as we are moving closer and closer to gene therapy, we need experts in gene therapy who are also caring for our patients. And I'm not just talking medical doctors, I'm talking nursing, I'm talking all allied health professionals. And we're not really anywhere close to that at this point. But this is just to illustrate, if we want to really provide precision medicine for lysosomal disorders, we have to start thinking about these things. So with very few exceptions, in general, lysosomal clinics are run by metabolic docs who are pediatricians in standalone pediatric centers. And what they do is they refer the patient, you know, you need, you know, specialty X, you get referred to that specialist. And those lysosomal clinics are within metabolism units, which are within genetics divisions and departments. So you tend to find that in larger centers. This is not necessarily the case in more rural areas or smaller centers. And even if you have a pediatric patient, being in a small center again presents the issue of not all the specialists are available to your patient, which your patient again will need to travel. The lack of there is definitely a lack of adult care infrastructure within the pediatric centers and raises many, many challenges. For me, I see this quite often being at a pediatric center it's most accentuated when my patients need psychiatric care, obstetric care, or gynecological care, which is definitely something I cannot provide at a pediatric center and very difficult to access, especially if your patient is admitted at other adult center. You have to wait till your patient is an outpatient and then you refer them. Really not ideal way to deliver care. In addition to that, due to workforce changes post-pandemic, reduced human resources and other resources, pediatric hospitals now are moving more and more towards incorporating age limits. So what's happening is now you're going to have to refer your patient to an adult center for various systems, and there's no integration of the electronic health records. That can be very problematic, as I mentioned, for continuity of care. In addition, you have the lack of awareness. So if I wanted to send my patient to an adult orthopedic surgeon for a hip replacement or a knee replacement, there are very few adult orthopedic surgeons who can see my patient, who have the experience of lysosomal disorders or MPS, for example. So not only do you have the physical center separation, the electronic health record separation, you have the lack of the knowledge, and then you yourself, as someone who has this knowledge and trying to to create this surveillance plan for your patient and give them the best outcome, have to do this extensive communication and collaboration with all of these providers, which in itself requires infrastructure and processes which most of the time are not in place. So I think, you know, I'm really trying to show some of the obstacles that I'm facing with my patients, be it pediatric patients or adult patients. There are some other care models. So I mentioned the more common care models. There are some other care models. For example, expert pediatric center with an official affiliation with an expert adult center with established transition processes for the patients, starting at the age of 16, and there's a specific process until the patient is 18 where they're completely transitioned over to the adult center with electronic health records easily moving with the patient. There is continuity of care, and the providers, because they're at affiliated centers, are in very close communication with each other. There are also a few examples of standalone lysosomal centers that provide whole person care across the lifespan. I feel that does give you the best outcome and would be the best model going forward. But of course, there are all kinds of things that one has to think about if we wanted to have that model countrywide. So I have questions more than I have answers. How can access to multidisciplinary care to both our pediatric and adult patients be improved? And I will ask the audience for ideas. How can we provide better transition processes, as well as increase the knowledge for adult onset conditions with adult providers, so the care does not have to always be in a pediatric center, which is not appropriate for age appropriate for an adult patient. So I think maybe I should let me finish and then we can talk about it at the end. So in my opinion, I think there are multiple things to think about. First is education. I know we've been talking about this. We've been talking with our industry colleagues about education of providers, but I feel the education is not just the education of providers in practice right now, but has to start early on and has to start in medical school, in residency, and not just trying to catch very busy providers to give them information. So that's going to be an essential part of the solution and requires collaboration with medical schools, deans of medical schools, so on and so forth, department heads. We also need frameworks. We need processes. Currently, you know, as many of you know, every center has slightly different framework, different process. Patients get different types of care depending on where they go. And ideally, this needs to be streamlined a little bit. I don't think single universities or single centers can do this alone. I think it has to be a wider collaboration, and maybe it even has to come from a governmental level, like a state level support, funding, obviously, and collaborations. And I think those are the categories where I feel the innovation is going to come from to change the care model that is available right now. There is definitely an urgency to change it. I don't see how we can continue with the current care model and have 5 or 6 types of gene therapy available for treatment, but still be caring for the patients using a model that is a few decades old. So I'd love to hear from the audience, and I think there may be questions. I'll leave it with Dr. Goker-Alpan if you wanted to take that, or James.
Actually,
but yeah. Okay, go ahead.
Yeah, there are a few comments and questions, and I guess this is going to actually start a conversation. Before I start actually reading the questions and comments verbatim, how we started about 10 years ago now as a standalone center, which is probably one of a kind in US, if not in the world, that with an aim actually to provide easy access to expertise without the convolution of the whole system. And truly, the system does not allow this kind of approach because the patients are so complex, the families are most often neglected, and the expertise is lacking. And so this really doesn't work with the current practice of spending 15 minutes with the patient and looking and writing your note most of the time. And this is what we try to provide. However, then we face with the education issues and then the funding issues. The reason is mostly, as you said, it probably needs to be taken at a state, maybe a federal level, but we know the most grants actually go to these very large academic centers for code by code rare disease or the donations, and the academic center will pick and choose what their interest is, okay, to put them on from level A to level B. It is not necessarily what the patients need. So these are actually some of the issues that we need to start talking about, and about the expertise too. And expertise, fortunately and unfortunately, requires numbers. So basically, I understand each university, academic center, large hospital can be code by code the centers of excellence, seeing 1 or 2, 3 patients. However, truly, like the surgery for Gaucher disease, is that right? Now we don't have too much surgeons to deal with this issue. And so we have less and less surgeons that are indeed experts to deal with the bone issues in an older patient that requires a repeat hip surgery. And then this requires patients traveling and, actually going to uncharted territories, which occasionally is a must. Like, for the MPSs, we know that one hospital is the hospital of orthopedic care for the MPS patients. Literally, I would rather refer my patients to that place rather than, trying an error for something that is so rare. I mean, I'm going to give myself as an example. My child required splenectomy, and splenectomy is not something done very often right now. And so we had to travel to out of state, stayed at a hotel, and then we had to come back while he was actually still sick because, we had to tend our affairs. So unfortunately, there is still there will be unbalanced issues, but I'm going to start reading the questions because there are really some interesting comments and questions here. First, this is coming from a family, I believe. So I'm going to read verbatim just so that the others can hear that too. So based on our lived experience of 19 years with ASMD, which is Niemann-Pick, AB, the concept of the Center of Excellence for Disease-Specific Care is working against our ability to access quality, sustainable care rather than for it. I would love to see efforts to de-emphasize the pressure we are put under to seek care at these centers. So basically, they are giving a standing ovation to you. So how would you comment on that? I mean, obviously, we need centers of excellence, but, how we can actually get this into the community and then try to be more approachable to the patients.
Thank you so much, Dr. Goker-Alpan. Thank you so much, Kara. I mean, that's you're absolutely right. I would love nothing else than to have my patients get local care. And I'm constantly thinking about this issue because it's just not sustainable to drive 6 to 8 hours to get an infusion of an enzyme and then do it again next week and then doing it again next week. And there are multiple children, there are large families, people have jobs. I have patients who can't afford parking, or the car breaks down in the middle of the drive to the infusion center. We need infrastructure to have this care locally. And, I, like myself as a physician, I don't really have any power to make this change, but maybe we need to start lobbying state governments. Why are there states that don't have this care? Can they fund care like this? And the larger centers, at least for myself, I would be more than happy to support other centers to have this care locally for the benefit of my patient. It really, I don't want to see patients suffering just to get care. It doesn't really make a lot of sense. But that requires big change and requires highlighting these issues at a higher level, at a national level. Maybe this is something that the National Organization for Rare Disorders would take on, lobbying governments and so on and so forth. But I absolutely agree with you.
Yeah, so that's the other question is guidelines that promote the concept of the team approach care, but that is not simply not practical outside a rare disease. We're coming to the excellent centers of excellence. Is this concept of need of changing? And if so, no, how? So basically, that is, we discussed a little bit the community and what might be the other steps.
No, absolutely. I think it's definitely not practical. I like the idea of the care within the whole person care within one center, because the idea of having specialty rare disease centers is great, but we are forgetting the geography. And when you're dealing with large countries and lots of rural areas and many patients who just are unable to access, it doesn't really make sense, because it puts the burden on the families and the patients. That I have families, for example, who had to leave their job, and they don't have the financial means to do that, but they had to, just so that they can go to their infusion. This is not sustainable, and they have multiple children with the same lysosomal disorder. Again, we need education, we need framework, we need funding, and we need that care available in multiple smaller centers so the patients can access it locally.
Yeah, also there is another question, or actually comment maybe. So it says, I'm going to come to telemedicine too. There is another, probably it is a blessing and a curse at the same time, and we can discuss the telemedicine for complex patients. So first, the current models proposed could be good, but they do not account for patient moving or traveling long distances. They usually require the patient. I mean, even like getting, like, let's talk about gene therapy. Obviously, gene therapy, I mean, it's still at the dawn of the of its time. It is very early, but these is not going to be administered by your, at a local hospital. So basically, there are so many things as we go by that needs to be followed and be vigilant and, follow the complications, even the administration. So can we ever circumvent the patients ever traveling? Like, I'm going to tell how we do our model. So basically, we require to see the patients at some point, but we also team up with the local doctor, either a pediatrician or internist or whoever is giving a wholesome care to the patient. And then we help with the like complicated things like having a prior authorization for enzyme therapy or arranging for these complex procedures. And some of them actually require coming to our site because, like, I'm going to give a very simple example. MRIs, there are certain views of the MRIs that need to be done and certain measurements, like in heart MRIs. They do an MRI, but I don't have that result from a local center. So basically, that is something, the whole procedure goes in vain because this is not the information I require. Similarly, some finesse things, like in looking at the bones of a Gaucher patient, could be missed by the local radiologist. So still, either for technical procedures that require expertise on the issue, or the expert care, unfortunately, is not widespread and will never be widespread, actually. So there is going to be some give and take in the whole situation.
I mean, Ozlem, this issue is further accentuated. I kind of had a couple of words on this, workforce issues. There are less and less people, medical students or residents, going into rare disease, going into lysosomal disorders. So we don't even have enough providers for the future. And if those who are in the field are concentrated in certain areas, this further accentuates the problem. Can we have training for primary care providers? Can there be some sort of course? They would not be rare disease experts, but at least learn a few of the ins and outs so they can provide some of that care closer to the patient. Maybe that's a model to look at. I know that there are a couple of places where this was done, but this is a real significant issue. And with regards to the telehealth, I mean, we had this experiment with telehealth for 2 years during COVID, and I converted overnight to 100% telehealth, and I see patients across all conditions, not just lysosomal. And while telehealth is great, you cannot examine the patient effectively. I have a patient with neuronopathic ASMD deficiency. I could not see the extent to the worsening of the contractures until I saw my patient in person. And this is the problem with telehealth. So depending on the type of disorder and the severity of disease, telehealth can be great. But if you need to do a physical exam, it's really quite problematic.
And actually, which is usually the case. And when obviously telehealth is a structure visit, the reason is you're doing virtual and you cannot observe every single thing, because the whole evaluation is not only limited to the exam. I mean, you go into the room and you start listening how the patient talks, how the patient acts, and there are if their accessory muscles are moving, like for a muscle disorders, so and so forth. I mean, the exam doesn't start actually in the exam room. The exam starts as you enter the room. I mean, you look at the face, that, and you recognize some of the things even before you examine the patient. So that takes the telehealth takes that opportunity. I mean, you can obviously observe some of the things, but not to the whole. And also you need to cover so many things in a certain period of time, which is not possible with the telehealth. And I see patients, that are referred code by ataxia and diagnosis of differential diagnosis ataxia through telehealth, which I think is not possible. Similarly, I have seen patients, coming with a very complex disorder and just being evaluated by a telehealth, and obviously they need a whole head-to-toe kind of approach and evaluation. So telehealth is good as far as the approachability, but it gets very limited due to the complexity disorders and when you're dealing especially with the neuronopathic form. So we use telehealth usually to disclose results. So you're still face-to-face and the patient doesn't need to come to, to the clinic, but we can still offer, review the labs, show the results, compare the previous results, even, show them x-rays. So there is a great opportunity as far as what we can share without, requiring the patient to come into the clinic. But obviously, I mean, it gets quite limited for the complexity of the disorders that we deal with. I think we may have one question. That is, let me see.
I think there's an interesting question by Rita. With all the mergers of larger hospitals buying all the local regional center, can a network be formed to enable expansion of services? I think this is actually a really interesting concept, Rita, and I wonder the same. As long as the regional centers that are being acquired by the larger hospitals are making services available for rare disease patients, because sometimes they will acquire them and they will assign, oh, this is going to be an outpatient radiology center. So as long as there is going to be actually access to rare disease care, I think that's a very interesting idea. And I think we have something similar in Boston, but it's really still not extensive enough, especially when I'm trying to provide care to other states like Maine or New Hampshire. It's really quite a struggle.
There may be one side, I feel like David Downer here, but when these mergers happen, actually that happens mostly in individual practices, in the private settings, usually either the venture capitalists or larger hospital systems purchase those practices. And obviously these larger systems, they do have their own, how they run the things. Okay, so basically, this takes the freedom out of this local center, how they would accept the patients. Like, I'll give example for us. So basically, we accept the patients with no strings attached, meaning whether they have insurance, they don't have insurance, they're coming elsewhere, so on and so forth. So basically, our main attitude is to provide care if it needed. But obviously, if we were to be bound by a system, then I am sure I would be required to ask what their insurance is. And we know that even for the clinical trials, most centers that run very complicated clinical trials, which they're no cost to them because they're all, contracted, sponsored studies, but they still require the patient having an insurance that is accepted by the system for the incidentals. The reason is things happen. Obviously, this becomes a big issue. Like, I wanted to refer a patient for gene therapy, and the patient did not have appropriate insurance, and we kind of couldn't find a place because the main centers that were offering was not taking the insurance to the patient of this patient. So that was a big issue for us.
That's actually a really good point, Dr. Goker-Alpan, about insurance. And this is why I think maybe there needs to be some lobbying done at the state or the governmental level, because there is definitely unequal access to patients based on insurance. And as someone who's practiced a lot longer in the Canadian system, it's very unusual for me, but it's a real issue that I see happening all the time. And I don't have really, again, resolution as a physician. That has to come from higher leadership, but maybe something else to put on our wish list for how we can change the system going forward is by involving state governments more and more.
All right, I guess there is one last question. So it's talking about the larger systems. So I'm trying to read it. It seems as many times when large system acquire a small regional hospital, one of the first things is to be discontinued are the pediatric services. I truly agree with that, and also complex care services, because these, like genetics, actually, I'm going to give an example. The reason is what we deal with are very expensive disorders, which not much income. Okay, so basically you have to devote your time and energy for a patient that needs care. However, the biller and billing practices only allows this much. So basically, we're never profitable for a large system. That's why we got rid of almost immediately, unless, it's like Boston Children's, or, is a big, reputable system that will just keep what we offer as, because it will bring them good reputation.
Yeah, I don't know what to say. This happened in Boston very recently. Actually, a large center just closed down their pediatric services, and all the pediatric services were moved to Boston Children. And it's a real problem.
Yeah. Okay. So maybe one last, let me see, comment here. So actually somebody is commenting. It says they say this is not a unique to lysosomal disorders. And giving an example, the adult congenital heart disease, as the diseases are rare, two different establishments, different adult and pediatric, are needed, and are they cost effective? Like having an pediatric system versus an adult system such that are cost effective.
I don't know. I'm not sure, actually. This is a good question. I'm one thought is you're right. It's not unique to lysosomal disorders. One thought, which I think is more facilitated in the US versus Europe and Canada, is whether you have providers who are both pediatric and adult trained who can provide care for both. But again, that doesn't solve the problem of the different institutions with the different infrastructure. So that's a good question. I don't know.
Yeah, exactly. I mean, different different countries have different systems. So we know like UK has an adult and pediatric, and there's a transition team. And I know in Germany there are some centers that are per se lysosomal, and they will take care of both adults and children. And I guess there is not one easy answer to this. Similarly is the expertise and also the training and education. I believe this concludes our session today, and thank you for attending. And we thank Dr. Vola Al-Hertani for this wonderful presentation, but not only for the presentation, for this very lively and very timely discussion that opens actually more questions than answers. So we definitely need to more discuss on this subject and maybe have a whole symposium on it. So while we are closing, we thank to all our supporters for this continuing medical education program, and we will invite you to the next one in a few months. Thank you.